Greetings, I'm dr.chan, neuropsychologist in Miami, faculty at Pepperdine University, and the founder of the Center for Neuropsychology and Consciousness. Welcome to the CNC interview series. My next guest is Dr. Philip Harvey. He is a professor of psychiatry and director of the Division of Psychology at the University of Miami Miller School of Medicine, as well as senior research health scientist at the Department of Veteran Affairs. He was the senior author of one of the top 15 most important papers of all time in clinical and applied neuropsychology, and ranked by Thomson-Reuters as one of the most highly cited researchers within the top 1% in the field. He has received a number of awards, including the Inaugural Schizophrenia International Research Society Clinical Scientist Distinguished Contributions Award. In this interview, we begin by covering what schizophrenia is, beyond its common associations with hallucinations, and what delusions are. We further talk about the bicameral mind theory from Julian Jaynes and evolutionary viewpoints of schizophrenia. We dive deeper into hallucinations, health conditions, and its genetic and neuroanatomical basis. We also talk about the gut brain, inflammation, and the immune system. Moreover, we discuss schizophrenia in children and its consideration as a neurodevelopmental disorder, as well as its impact on IQ, the myth that violence is more prevalent in schizophrenia, and how this condition may impact cognitive functioning from multiple perspectives. Finally, we end by discussing the best treatments for schizophrenia, as well as novel treatments in the works. Feel free to skip around if there are particular topics of interest to you. The first thing that I think comes up for most individuals when they think of schizophrenia are the positive symptoms, things like visual hallucinations or auditory hallucinations. Could you maybe start us off by describing the condition in more detail, including symptoms that might be often overlooked by the DSM or otherwise?
Sure. Schizophrenia is an old concept. It was originally defined by Emil Kraepelin back in the late 1890s. And the idea was that schizophrenia, in Kraepelin's view, was a condition that had a large number of approximately equally important symptoms, hallucinations, delusions, and also other functional impairments, because he called it dementia praecox, and he knew about dementia because Alzheimer was one of his students. So he focused on the idea of functional impairments as well, and described every cognitive impairment in schizophrenia that you don't need a computer to measure back by 1910. The term schizophrenia itself was coined by Eugen Bleuler, who is a Swiss psychiatrist, and the term has led to a lot of misconceptions. Schizophrenia means splitting of the self. It's not split personality, multiple personality, anything like that. Bleuler also believed that there were multiple important features of schizophrenia, including cognitive impairment, communication disorders, and negative symptoms. He was less focused on disability than Kraepelin, and his concept of schizophrenia was wider, probably because he worked at a different kind of psychiatric institution.
Okay, excellent. Thank you for that summary. Now, I wanted to focus a little bit on delusions. A great example of delusions actually comes from the studies in Michigan in the 1950s with Milton Rokeach, where I think he brought together three individuals who all believed they were Jesus. And after 2 whole years of manipulation and questioning, the delusions persisted. What's the current understanding of the origin of delusions, and are these delusions mechanistically different from things like delusions in delusional disorder?
Well, that's a very interesting example that you bring up, because I think Three Christs of Ypsilanti is one of the most informative books ever written, because it highlights two things about delusions. Number one, the fact that people who are delusional can recognize delusions on the part of others. So it's not a wide-ranging loss of reality contact. They know it's not possible for Christ to be there on the same treatment unit as they are. But at the same time, it also highlights another feature of delusions, which is resistance to deconfirmation, or disconfirmation. People who are delusional are very likely to argue against any suggestion that what they believe is not completely true. Now, what is the origin of delusions? Well, obviously, delusions originate internally. And some research that I've done shows that people with schizophrenia are actually much better able to remember information that they generate themselves compared to information that comes from the outside. That's called the generation effect. And the generation effect is much more powerful in schizophrenia than it is in healthy people. And so, as a consequence, people with schizophrenia who have delusions are quite likely to remember them. It's very common for delusions to recur across episodes. And one of the features of delusions in schizophrenia used to be referred to sort of disparagingly as bizarre delusions.
Mm.
What that means is they are completely implausible. Delusions and delusional disorder are commonly quite plausible. My wife is stealing my money. My neighbor was in my house.
Mm.
The housekeeper took something rather than I misplaced it. So
Mm.
they are delusions and delusional disorder, or even in dementia, are commonly linked much more into plausible reality than delusions in schizophrenia.
Mm. Okay, excellent.
And it's
Uh,
interesting, one more comment,
yeah.
delusions always seem to be at the technological cutting edge. When
Mm.
Kreplin was writing his book, Dementia Praecox and Paraphrenia, he mentioned that a lot of the delusions that his patients had were focused on the indoor heating pipes because they just installed indoor heating in the hospital for the first time, and the steam pipes, the latest technological advance at the time, were the source of many patients' delusions.
Wow, that's fascinating. Didn't know that. So, my next question's a bit of a leap, but I'm definitely very curious about your opinion. It refers to the bicameral mind theory from Julian Jaynes. And for the listeners out there, Julian Jaynes speculates that in ancient times, people may have experienced a divided mind, right? That where one part of the brain would communicate with another part of the brain through auditory hallucinations, which individuals perceived as external guidance from, let's say, the gods or other authoritative figures. Now, as an example, he uses the Iliad or the Bible. And in schizophrenia, individuals may experience auditory hallucinations such as command hallucinations, which bears some resemblance. So it's a controversial idea, and it actually recently emerged in a popular show called Westworld. Now, I'm wondering if you could share your thoughts on this theory.
Well, the elements of the theory clearly explain observable phenomena, and the idea of there being widespread experiences that are sort of outside the realm of what we would consider normal or normative has to
Mhm.
have been happening during the times of the Iliad or in the Bible, because there's a lot of appearances of gods and all kinds of other events that would be viewed as not likely to be the case. Further, auditory hallucinations tend to be quite personalized in people with schizophrenia.
Mhm.
Some of the central tenets of important hallucinations are voices spoken directly to the person,
Mhm.
or hearing two voices talk to each other about the person. And as you said, command hallucinations, where orders are directly given to people. Now, I think one of the things that James was trying to make, one of the points he was trying to make, is that perceptions of time and space and continuity were also different at that point as well, with
Mhm.
fewer external reference points, no way of knowing what season it was, all kinds of different things where there are lack of observable, consensually derived anchors that people agree on now. And I think it's also important to keep in mind that there are certain kinds of hallucinations that occur in people that are not viewed as pathological at all, such as what they used to refer to as hypnopompic and hypnagogic hallucinations,
Yeah.
where you're hallucinating when you're in a half alert going to sleep state. And it's very common for people to have those experiences, and there's actually nothing pathological about it. It's not more common in relatives to people who have formally diagnosed schizophrenia. So there are a lot of experiences like this going. In Oxford, England, for example, there's a club which is composed of people who hear voices, and they're called voice hearers. But they acknowledge that the voices aren't really happening, that they are hearing them, and they go to meetings actually at Oxford University to talk about their hallucinatory experiences. So it's a very interesting phenomenon, and there's a gradient of experience from normal to abnormal, And I think the point that determines when it's abnormal is the point that the DSM-5 uses. If it causes a major impairment in your functioning, then
Hmm.
that would be something that we would consider important enough to be diagnosable.
Hmm. Yeah, that's indeed really interesting. And it's also, we could say, partially culturally mediated also, right? Like with Haitian demographics, it's common that after someone has passed away that they may see or hear voices from them, and that might be considered absolutely normal.
Hmm. Yep.
So is it possible then, for example, to say that schizophrenia could be a condition whereby our brain regresses to an earlier evolutionary stage in development, or would that be too far-fetched to say?
I think I wouldn't say it's an earlier evolutionary stage. However, there have been a couple of relevant theories. For example, Tim Crow, very well known British psychiatrist, spent a lot of time writing about how schizophrenia is uniquely human. So it must therefore be a disease of the left hemisphere, which is the language hemisphere in humans. Says
Mm,
even in the highest primates or any other animals, there is no sign of anything that resembles schizophrenia. So he thinks it is language mediated. So, in a sense, what we're talking about is it is at the highest level of evolutionary attainment, but the abnormalities are focused on challenges in managing language related things. So, I think that's a interesting concept. The other thing to keep in mind is that one of the currently widely accepted theories in neuroscience and schizophrenia is the idea of hyperfocusing.
hmm,
So, in other words, hyperfocusing means that people with schizophrenia may focus on an overly narrow field of information. So, if you imagine that your narrow field of information was an idea that you yourself had gotten previously, that may not exactly be true. The more you focus on it, the more ingrained it becomes. People with schizophrenia develop false memories with fewer exposures than healthy people do as well. So there is a component of suggestibility as
mhm,
well as, uh, mismatching your abilities to the tasks at hand. We've just recently done some studies where we showed that people with schizophrenia are extraordinarily good at remembering their own responses when doing neuropsych tests, like the Wisconsin card sorting test, but
mm.
they have a major challenge in remembering the feedback they got. So if
Oh,
all you remember is if you thought you were right, and you don't filter that by whether or not you heard you were right, how are you going to solve a test like that or other real world problem solving challenges?
mm. Interesting. Yeah. From an evolutionary viewpoint, uh, evolutionary theories attempt to understand certain conditions through having evolved for some particular reason. And part of the issues, I guess, they view some of these conditions as arising is that they're no longer functional in our society. I'm just wondering, is there an evolutionary hypothesis to schizophrenia?
Well, Crow's hypothesis is the primary evolutionary hypothesis.
Okay.
And one of the arguments is that when you think of all the other features that are present in primates, language is really new. And
Hmm.
so, if you think about that, language is really new. So, maybe there's only been 10,000 or 12,000 years to work out the kinks of sophisticated language. So, consequently, as a late developing feature, maybe the wiring isn't all in place right now. So, his hypothesis was that since most features of schizophrenia that are important are, in fact, language related, hearing voices,
Hmm.
having beliefs that are quite verbally mediated, and even on the negative symptom side, having a major feature of negative symptoms being underproductivity of verbal output. His idea was that his idea was that things aren't exactly sorted out yet. And that's the evolutionary part of it. Motor skills and things like that have been around for millions of years in primates, but we don't know when language as it currently is, including symbolic things like that,
Hmm.
took place. I mean, obviously there are paintings on the walls in caves and things like that, and obviously the Egyptian system of hieroglyphics is a symbolic language system that was
Hmm.
developed many years ago. But if you still think about that, Things like the other elements of functioning are millions of years older than language, and that was the argument that it's something about language abnormality that gives us this uniquely human illness.
Hmm. Hmm. Okay. And when it comes to hallucinations, auditory, visual, or otherwise, they're not usually random noise, right? They're usually recurrent. They're usually something that's, well, repetitive. And it seems to point to operating systems in the brain that, uh, that are consistent. And I guess I'm curious to know if hallucinations can be viewed as expressions of a fractured personality, or that personality itself is composed of a multiplicity as opposed to, a unified singular whole.
Typically, people with schizophrenia hear hallucinated voices that are criticizing them or commenting on them. There have been some hypotheses that both delusions and hallucinations have a common origin in attempts to avoid experiences of low self esteem. So, in
Mm,
other words, if something bad happens to you and it's absolutely not your fault,
mhm.
then how could that how could that reflect on you? And voices that speak to you and tell you what to do and criticize you could very well be related to that. I mean, I think that there is a common element of misperception in separating different information sources. I think that many positive psychotic symptoms are actually related strongly to source monitoring.
Mm,
People will express delusional beliefs and tell you that they heard them somewhere or they learned them somehow. Voices are obviously perceptual experiences that are being misidentified as originating outside instead of internally, because people actually do show evidence of brain activation, at least in some studies, showing that their brain is acting like they're really hearing something, but they're
right.
not.
Hmm. Okay. So I'm going to pivot now a little bit. And, I know that there are, well, multiple health conditions, such as obesity being a significant one that's associated to schizophrenia. Could you share why this might be the case, and if there are other salient health conditions that stand out?
Well, there are a tremendous number of health conditions common in schizophrenia, and the average life expectancy is about 15 to 25 years less, depending on the country, than the rest of the population. Most deaths from schizophrenia tend to be cardiovascular.
Mm,
Uh, Being overweight, having metabolic syndrome, and type 2 diabetes are very common.
mhm,
So one of the things that we think is that certain antipsychotic medications cause weight gain. Maybe that's partially responsible.
mm,
Another thing that happens is negative symptoms such as avolition and anhedonia reduce your motivation, so people tend to sit a lot. And in fact, we've
mhm,
done studies using ecological momentary assessment and characterized activities as active versus passive. And one
mhm,
of the things that you see people with schizophrenia doing is
mhm,
sustained seated multitasking and not productive multitasking. So there are elements of the treatment for and features of schizophrenia that lead to health problems. But it's also important to keep in mind that when you look at large scale GWAS studies, when you look at factors that are associated with schizophrenia, there's actually genomic overlap in risk for diabetes and obesity and metabolic syndrome
mhm.
with the genomic signature of schizophrenia in general. So it might turn out that this is an illness where these things actually merge together.
Right.
And the GWAS can't be is not likely to be affected by the consequences of different experiences, because it's a DNA assessment, not an RNA assessment, and you're
Right.
not looking at changes in expression over time. But I
Mhm,
think there's some reason to suggest that some things that we blame the treatments for may be intrinsically related to the illness, and
mhm,
that's probably where the connection between sedentary behavior, negative symptoms, and underactivity come together.
mhm,
Another thing that happens is there's a very unique phenomenon in schizophrenia. It's been studied by a few different investigators. It seems that for some reason, food choice and food preparation skills are among the most impaired in people with schizophrenia. It's like they're disproportionately challenged in figuring out what they should actually be eating and how they should be cooking it. And that's
mm,
a really fascinating possibility,
mhm,
because if you combine not having good cooking skills with not having very much money, that sort of puts you on the 7-Eleven diet path, And the problem is, the $3.50 7-Eleven lunch would
Mhm.
require walking 60 miles to burn up all those calories, right?
Mhm.
So even if you're tremendously active, the food intake, the food intake that people are having
Mhm.
could very well be a part of a complex matrix of
Right.
different things.
Yeah. Yeah. So, on that same line of thinking or questioning, then we know that schizophrenia is highly heritable. That there are even studies showing that family members without the diagnosis exhibit similar frontal differences as individuals who have
Yep.
schizophrenia, such as with people who've been tested with the Wisconsin card sorting test, which you alluded to earlier. Um, Now, schizophrenia has several genes associated to it. I think from the last research I looked at, it was like up to 25 known genes up to this point. Is this still the case? And, what genes in particular may play a more influential role?
See, we're actually up in the hundreds with the GWAS studies at
Oh,
this point,
okay.
and there's several really interesting phenomena. We've been doing a large scale GWAS study that's in veterans, and it started with a sample of 10,000 veterans with schizophrenia and bipolar disorder that we saw, and then concurrently, the Department of Veterans Affairs launched this program called the Million Veteran Program, where their
Okay.
goal was to genotype 1 million veterans and relate that to their health data. So
Mm,
what we have is we were interested in the genomics of cognition and disability. And is
mm,
there a direct genomic signature that contributes to disability above and beyond other factors? So, for example, we all know that some people who have cognitive impairments are still working. There are more people who have intellectual disability working at any given time than people with schizophrenia, despite differences in their overall intelligence.
mhm,
So, a couple of things that we have discovered are, I think, important. That, for example, there is overlap in the genomic signatures for bipolar disorder, schizophrenia, and major depression.
mhm,
That this may explain why there is sort of a overlap of the outcomes in the relatives of people with schizophrenia. You're absolutely right. One of the most salient findings that we see in schizophrenia is maybe 12 years before you have any psychotic symptoms, there are
mhm,
identifiable features of your behavior in cognitive and functional domains that retrospectively can go back and be detected. The
mhm,
role of cognition in developing schizophrenia, if you're at risk, is really important. They have shown that when at the time of first detection of the prodrome, people with the worst cognitive impairment are likely to be the ones who develop psychotic symptoms later. So
mm,
there's no evidence for deteriorating cognition in people who are showing a prodrome already. Their changes apparently have taken place before they show prodromal symptoms.
mhm,
And from the genomic point of view, you mentioned a spectrum with people who have various levels of impairment. That applies in cognition. But one of the studies that we were able to do in our very large sample of veterans, we had 645,000 of them in the study that we did,
mhm,
we were able to look at the level of certainty of the information that someone has a psychotic disorder and relate that to the polygenic risk score for schizophrenia.
mhm,
So, to make it a little bit more concrete, imagine that you looked in a veteran's medical record, and one time one clinician said, I think this person has psychotic symptoms.
mhm,
Another time, another person might have been written a prescription for risperidone, a common antipsychotic, but maybe never filled it. And at the opposite end of the spectrum, you could be someone who had been hospitalized multiple times, had continuous treatment with antipsychotics, or even having clozapine. So there's a gradient of closeness. And this is what people like Paul Mead talked about in terms of the schizophrenia spectrum. They talked about a predisposition that
mhm,
is present in everyone who develops schizophrenia and related conditions, but is
mhm,
expressed to different extents. And so what we
mhm,
found was that there was a really close correlation between the level of the evidence that was present in the chart that the person had a psychotic condition and their polygenic score for schizophrenia. And
mhm,
even people who had one mention in their chart one time of a psychotic condition had a higher score on the schizophrenia PRS than people who had no such information. And it was nice and linear all the way up the gradation of evidence. So it does suggest that there are things that are transitory, not disabling, but still detectable. that may have something to do with schizophrenia broadly defined.
Hmm. So, there's been some thinking about schizophrenia being better categorized as a neurodevelopmental disorder, given the enlarged ventricles that are commonly found and lower frontal cortical volume. Do you view it as such?
Yeah, I view it as a neurodevelopmental condition, definitely,
Mm,
with in some cases, a clear deteriorating, if not degenerative, component. So,
okay.
yeah, there are. Well, one of the things that's fascinating is people have shown in postmortem brains of people with schizophrenia expression of genes that are supposed to turn off when you're an infant, right?
Mm,
And so what happens is you see that there are immature genes expressing over the lifespan in
mhm,
schizophrenia as well. So so you do see these changes. You see educational changes. You see very clear a failure to mature, the later maturation of frontal lobe or incomplete maturation of frontal lobe over time. So there's very little argument about that.
okay.
And this is why the concept of understanding the genomics of it are important, because
Mm,
if you're thinking about intervening, the question is, when do you intervene, who do you intervene on, and what do you do?
mhm,
Studies of people who are prodromal, who have lots of subthreshold schizophrenia symptoms, have shown that antipsychotics don't prevent progressing to developing the overall condition. So you certainly couldn't start treating that early on.
I see. Okay. So I wanted us to move away from the brain and into the gut. There's been a lot of hype about the gut-brain axis and the enteric nervous system. Um, I'm wondering, have there been any findings related to that that's worth mentioning?
Yeah, well, people are definitely finding microbiome alterations in people with schizophrenia. It
Mhm,
may be part of the polygenic risk for the illness that includes risk for, gastrointestinal conditions as well as schizophrenia itself. But
mhm,
clearly, gut microbiome seems to be important. Now, the directness of the relationship of that to the other features of the illness is yet to be ascertained. And I think that one of the things that may be the case in schizophrenia is it does seem to be the case that the blood brain barrier is more permeable in people
mm,
with schizophrenia than it is in the general population. So I think that's a very important finding, because what that might mean is that the shield that you get from toxins in the periphery might be down. And it might
mm.
very well wind up that things, exposures, environmental or otherwise, that would not impact on people whose blood brain barrier is more permeable.
Hmm. So similarly, there's, I think, some hypotheses about the contributions of the immune system as well as inflammatory processes. Could you elaborate on that a little bit?
Yeah, there's very little question that inflammation is involved in lots of different conditions.
Hmm.
And one of the things that is the case is that inflammatory conditions can also impact on things like glutamate GABA balance, which is the regulatory system by which
Right.
dopamine, glutamate, and actually acetylcholine all stay in balance. And
Hmm.
inflammation clearly has impacts on that. There have been some findings, although not always replicated, of people with schizophrenia having greater indications of brain aging than healthy people. One
Hmm.
of the things that we have looked at in our research is people's cognitive performance, and when they start to show age-related cognitive changes, and that appears to be earlier in people with schizophrenia, which is also something that could have an inflammatory component as well. And inflammation also affects your mood and your motivation, and not
Right.
just hard cortical functioning at the neurotransmitter level.
Hmm. Hmm. And when it comes to the neurotransmitters, one of the great hypotheses is the dopamine hypothesis, right? So the assumption is that there's a hyper dopaminergic functioning in the mesolimbic system, which explains or at least is correlated to the positive symptoms, and then we have dopaminergic systems in the mesocortical system that relates to the negative symptoms. Is that theory, does it still stand as the core theory, or are there other ones that might include things like glutamate and serotonin that have Sort of.
Yeah, well, it's interesting because I just made a slide set for a talk I'm giving in a couple weeks on that topic.
Oh,
And
wonderful.
yes, there's no question that drugs that block dopamine D2 receptors in the striatum reduce the symptoms of schizophrenia. But
Okay.
that does not prove that alterations in dopamine are the cause of schizophrenia. There's several other points of entry. So,
Mm-hmm.
for example, reductions in transmission at the glutamate system, uh, they call it the NMDAR, uh, at the at the cortical glutamate receptor site, which involves NMDA, as
Mm-hmm.
well as glycine. And one of the things that happens is if you down regulate the NMDA receptor, it upregulates striatal dopamine functioning. So what people have been trying to do recently is to upregulate the NMDAR to see if it would downregulate cortical dopamine functioning, and it's important. Also, it's recently been discovered that in terms of the muscarinic cholinergic system, there are a couple of really important receptors for schizophrenia. One is M1, which is the receptor which is responsible for cognition, particularly episodic memory, attention, and vigilance. But then there's also M4. M4, when you stimulate the M4 receptor, what that does is that downregulates presynaptic dopamine release. So
Mm-hmm.
you can actually downregulate dopamine without blockading the receptor. And it turns out that receptor blockade is almost always a bad idea. That's why when you take a look at conditions like major depression, people have always had better luck with transport inhibition compared to agonist or antagonist approaches at serotonin or other neurotransmitters. I mean, obviously, you'd think, whoa, if low levels of serotonin are or low levels of norepinephrine are associated with depression, why shouldn't we just stimulate norepinephrine? Well, because that is also associated with psychosis and things like that. So
Mm-hmm.
it turns out that there's a complex situation where alterations in functioning in glutamate and GABA can up and down regulate the dopamine receptors in those critical areas. And
Mm-hmm.
it turns out that if you have a drug that hits M1 and M4 at the same time, you could have a drug that enhances cognition
Mm-hmm.
at the same time as it downregulates psychosis. And in fact, there is a drug like that that's being evaluated by the FDA in the middle of the summer. It's called CAR-XT. It's a
Mm-hmm.
drug that is an M1, M4 agonist. It has succeeded as an effective antipsychotic in 3 double-blind randomized trials, but there's
Oh,
also substantial evidence that at the same time it improves cognition.
right.
So there may be a standalone treatment that actually downregulates dopamine and upregulates cognition without the challenges associated with dopamine receptor blockade,
Right.
EPS, prolactinemia, because the typical D2 blocker hits every dopamine receptor,
Right.
which reduces prolactin, which
Mm-hmm.
elevates prolactin, causes movement disorders, and all kinds of other challenges.
Right. Right. Sounds quite promising. And, lots of the complaints I've heard from patients I've seen who've suffered from schizophrenia are the side effects of some of these dopaminergic
It's
blockers.
it's a hammer to treat a problem that is probably more subtle than that. But
Right.
the thing we have to keep in mind is that this is the very first time
Mm-hmm.
that a drug that doesn't block the dopamine D2 receptor
Mm-hmm.
is seems like it reduces psychosis, but it still affects dopamine. So the
Mm-hmm.
idea is maybe you don't need to block D2, but we still don't have any interventions so far that
Mm-hmm.
improves psychosis without manipulating D2, whether or not you're
Mm-hmm.
blocking it or down regulating it. And a couple of other drugs that were recently developed but were suspended because of challenges with placebo effects during the pandemic
Mm-hmm.
also had the same kind of concept, which will operate presynaptically and control the release of dopamine rather than trying to deal with it after it's out.
Okay. All right. I want to take a step back because I think we've probably lost the audience a little bit here. But I wanted to ask you about the differences in diagnosis, specifically about with males and females. So, males, I think it starts usually the early 20s, whereas females, it comes in the later 20s, early 30s. Do we know what the reasoning is behind this?
Well, I think that part of the reason, I mean, there is some reason to believe that that estrogen is protective, so it may take a longer dose of whatever caused schizophrenia to cause those challenges. We
Mhm.
also think that males are probably more vulnerable to stress and insult before their frontal lobes have matured.
Mhm.
The features of schizophrenia differ across the sexes, with males being more likely to have more significant negative symptoms. There have been some studies finding greater cognitive impairments on the part of males. Females are better responsive to antipsychotic medications.
Mhm.
And I think that some of the stuff is differences in sex hormones uh, that may just be protective from the of things that are actually unfolding, occurring
Mhm.
in the same time frame. Females are less likely to get rehospitalized after a first episode. They seem to also be more responsive to interventions targeting awareness and insight than males.
Okay. And how about with children? Schizophrenia in children is far more or relatively uncommon, we'll say. How does their presentation differ from adults, and what are some telltale signs and maybe some differentials that people might consider?
Yeah, it's important because there's a constellation of childhood onset conditions that have very fundamental behavioral challenges. Remember, if we went back to Bloiler described autism in schizophrenia as being a phenomenon of social withdrawal, which was then picked up on by Kanner, who focused on children who had a primary disorder of social withdrawal. So, one of the things that's important is to separate out more versus less severe autism spectrum conditions from what might be schizophrenia. And it is actually quite rare for early onset schizophrenia to take place. One of the things that's extraordinarily challenging, and Judy Rappaport at the NIMH did a very long, like 25-year study of childhood onset schizophrenia, finding that in childhood onset, antipsychotic response is markedly attenuated. And as a consequence, kids who develop schizophrenia have a longer and more intense exposure of their brain to the psychotic process. We're not
Mhm.
sure exactly what else is different in childhood onset schizophrenia.
Okay.
We know it's not very common. We know it needs to be treated when it
Mhm.
first appears, because the biggest damage you get in schizophrenia after the illness onsets is having extended periods of time with untreated psychosis.
Okay. Are there specific environmental conditions that increase the chances for childhood schizophrenia?
Probably more genomic than environmental. I think the childhood onset schizophrenia tends to be more multiplex than adult onset schizophrenia.
Hmm.
But as far as environmental factors, I don't think anyone has nailed down much. There's
Hmm.
remarkably little specific environmental influence on schizophrenia. Obviously, stress
Stress. Yeah.
does tend to release the predisposition, but it doesn't seem as though there is a specific stressor, chain, except maybe physical or sexual abuse may have some more unique features.
Right. So traumatic conditions possibly. Now, one of the major misconceptions of schizophrenia is that the incidence rate of violence is higher in schizophrenia, when in fact it's lower than the general public. Now, in fact, what we do find is that there are higher rates of self injury, right? Could you elaborate on some of the findings there?
Yeah, well, there are a few of those things that are the case. First of all, people with schizophrenia are more likely to be a crime victim than a crime perpetrator, and that's something that's been replicated over time. Self-injurious behavior is common. A lot of it, though, may be due to psychotic symptoms, and people who injure themselves in non-suicidal ways are
Mhm.
often discovered to have had some kind of experience. Now, there violence on the part of people with schizophrenia is not completely absent, and if you mix certain kinds of drug use with psychotic conditions, then the risk for violence is higher. The people who are victims of violence are more commonly people who know the patient than strangers, even though people are very much afraid of stranger related violence. It's actually much more rare than violence that people gets committed against your family members or people who are offering you clinical treatment. I mean, one of the riskiest jobs there is working as a psychiatric technician in an emergency room like the Jackson Memorial Emergency Room in Miami or Grady in Atlanta, where there's a lot of agitated behavior. A lot of it associated with substance intoxication, though.
I see. Okay. I'd like us to now move into the domain of cognition, which I know is one of your specialties. On a typical IQ test, we measure things like verbal comprehension or perceptual reasoning, processing speed, working memory. I guess the first question is there a difference in general when it comes to IQ when we compare individuals diagnosed with schizophrenia with the general public? And if so,
Well,
what? Yeah, go ahead.
one of the things that happens is that if you give people IQ tests,
Yeah.
as you mentioned, IQ tests measure a whole array of different cognitive abilities,
Hmm.
including processing speed, working memory, and things like that. So if you've got a test, if you got tests of processing speed and working memory, which are particularly impaired in schizophrenia, and you say that's part of your IQ, then your IQ is going to be lower. One of
Right.
the things that you don't see in people with schizophrenia is markedly lower indices of educational attainment, like
Mm.
reading ability. Word recognition reading ability is pretty highly correlated with people's educational attainment and is one of
Hmm.
the abilities in schizophrenia that does not seem to be affected by the course of illness, sort of like in dementia. But one of the things that you see is that people's IQ at the time they develop schizophrenia is often around 90, and that's because of challenges in speed and working memory, which accounts for 50% of the tests that
Hmm.
contribute to your IQ score.
Mm.
The verbal comprehension part and the the perceptual parts are not as impaired. So it
Hmm.
is. There are a bunch of impairments in schizophrenia, but it's not if you think about intelligence like I do, is separating out things like verbal and academic achievement and then looking at other abilities. There's a disparity, and that's the source of the lower IQs.
Mm. Okay. Now, the other, I think, function that tends to be quite salient is executive dysfunction, right? And I guess could you share what types of executive functions are particularly impacted, and how does that translate to everyday living challenges?
Yeah, the most impaired abilities in schizophrenia tend to be processing speed, but it's important to keep in mind that if you have a processing speed abnormality, everything else turns into a speed test, even if
Mm.
it's not timed. Because if your cognitive functions are going slow, everything else is going by pretty fast. But there are clear, important executive functioning challenges. One is measured. One of the most commonly used tests in schizophrenia is called the Wisconsin card sorting test. It involves the ability to identify constructs through feedback and then sustain them until your feedback changes. So it tests the ability to identify the relevant construct, adopt a win, stay, lose, shift approach, which is a pretty good strategy for life in general. If it ain't broke, don't fix it. If you're solving the problem, don't change it,
Right.
and then the ability to flexibly adjust when things go wrong. Because in
Yeah.
the Wisconsin card sorting test, every 10 trials, you're told you're wrong, even though you'd been right 10 times in a row.
Hmm.
Another highly related executive functioning ability is what's called manipulation working memory. There's two types of working memory. One is maintenance. So if I read you a phone number and expect you to dial it, well, that's a pretty simple task. And
Hmm.
you can remember a phone number long enough to dial it. However, manipulation working memory involves the idea of taking information, holding it in your short term memory, doing something to it, and then outputting it. So,
Hmm.
from the sort of trivial test based perspective, if I read you a bunch of digits and I ask you to give them back to me forward, that's maintenance working memory. If I tell you I want you to give them back to me backward, that's
Hmm.
manipulation working memory because you have to hold them and then move them. And so manipulation working memory is commonly associated with things like if you're going shopping and you got a shopping list, you have to be able to adaptively keep in mind what you bought and what you haven't bought. Because if you have to check your list every time you take a step, it's going to take you forever to do it. So the manipulation component of working memory actually is highly correlated with performance on the Wisconsin card sorting test. So it
Mm-hmm.
probably is the case that there is a working memory component to the Wisconsin card sorting test and an executive functioning component to manipulation working memory. The
Right.
things are highly related to each other.
Mm-hmm. Mm-hmm. Yeah, sometimes I say that that working memory is short-term memory plus executive functioning.
Yeah, that's exactly when I think of it. That's exactly what it is. I mean, I think that you could refer to many elements of very short term retention of information that doesn't have any input, output, or processing demands. It's just short term memory, right?
Mm-hmm.
And the reason that phone numbers have 7 digits is because that is the capacity of working memory in most people. And it used to be, nowadays we have 10-digit phone numbers, but
Mm-hmm.
if you're calling within your own area code, that only counts as one item, right?
Right.
So,
Yeah.
and then
Yeah.
the 3-digit exchange at the beginning, back in the old days, when you'd live in a neighborhood, everyone would have the same 3-digit exchange.
Mm-hmm.
That has changed, but
Mm-hmm.
for example, it's not hard to remember that the area code in New York City is either 212 or 917, and
Mm-hmm.
so you can remember the numbers that way. So there are things that people in human factors have done to capitalize on what we know about
Mm-hmm.
both uh, short-term and working memory. And in some European countries, phone numbers have different numbers of digits in them. So for a while in Italy, fax numbers had a different number of digits than phone numbers, which
Mm-hmm.
is good for knowing if you're calling a fax machine or a telephone, but not so good for remembering the numbers.
Right. The other domain of interest is social cognition, right? There were some famous studies finding that there was, for example, hyperarousal of the amygdala when viewing neutral faces versus hypoarousal when viewing, let's say, a negative face, facial expression that would potentially lead to misinterpretations in social cognition. Could you elaborate a little more on some of the deficits in social cognition and again, how it translates to everyday life?
Yeah. Well, one simple concept of social cognition is cognitively demanding social acts. So, in other words, it's not cognitively demanding to recognize the difference between a human and a dog, for example. But the idea of recognizing facial affect expression is cognitively demanding.
Mhm.
So, emotion processing, which means expression and perception, is an important domain of social cognition. The idea, this concept called theory of mind, which simply is awareness into others' thinking processes. So, theory of mind means that you are putting yourself in the other person's position and trying to figure out what they would be doing. We
Mhm.
also are interested in the idea of attributional style,
Mhm.
interpreting why you think other people did things. It turns
Mhm.
out that emotion processing and theory of mind are related to social functioning.
Mhm.
And the idea of attributional style and things like that are commonly related to paranoia and aggression. Because if you
Mhm.
think people are out to get you, right, you interpret their intentions as negative and aimed at you, then that's a feature of paranoid ideation, but also leads to aggressive behavior sometimes. So
Mhm.
you need to be able to perceive emotions and to express emotions in order to communicate adequately with other people. And it turns out that social cognition is related to, but not is dependent on neurocognition, but not overlapping with it. So people who
Mhm.
have fairly significant cognitive impairments almost by default have social cognitive challenges.
Mhm.
And one of the things that we have seen in some of our research, and it's in line with your point that you just made about the sort of mismatch between cortical activity and demand, we have seen that when people with schizophrenia who have episodic suicidal ideation, if you
Mhm.
show them the same face repeatedly, they'll report that it's much more scary during time periods when they are having suicidal ideation, which means they're taking the features of the
Mhm.
face which are invariant and reinterpreting them to be targeted at themselves during time periods when they are in a self-injurious type mood. And when you mentioned the idea of amygdalar activity, one of the things that's fascinating about imaging in schizophrenia is that if you look at resting state activation in schizophrenia, it's actually higher than in healthy people. They seem to not be able to turn the motor off when they need to, but when you ask them to perform cognitive demands, they're less able to mobilize the activations. So there's a mismatch between cognitive demand, particularly externally originating
Mhm.
cognitive demand, and cortical activity.
Right. So does this relate then to introspective accuracy and how that, I know that relates to coping, and maybe you could share a little more about that.
Yeah, introspective accuracy is a concept that has grown in mental health, has
Mhm.
grown out of the old research on awareness of illness or insight. It
Mhm.
turns out that one of the things that makes psychotic symptoms psychotic is that people with schizophrenia aren't aware that the experience is non-normative.
Right.
So they think their voices are real. They think their delusional ideas are valid, and so they're
Mhm.
not aware that they might be originating from someplace else. And
Mhm.
sometimes their insight improves when they have a couple of treatment experiences where they get treated with medicine, and all of a sudden the voices go away, and it's like, oh, those things aren't going on all the time. So
Mhm.
maybe there's a connection. But introspective accuracy applies to the ability to report on how good you are or how well you have performed across domains. So we've looked at introspective accuracy for everyday functioning,
Mhm.
for cognitive performance, for
Mhm.
social cognitive performance. And a couple of the fascinating things that we've seen, and it links into what we talked about before
Mhm.
about excessive generation effects.
Yeah.
One of the things that you see is that people with schizophrenia will give you very implausible reports of functioning. We
Mhm.
found in a study we did that there was only a 30% overlap between people with schizophrenia and their case managers about whether or not the person with schizophrenia had a job. One
Mhm.
would think you would know if you had a job.
Right.
We just did a study where we found that people with schizophrenia who were home and alone, we did a 30-day study where we asked them 3 times a day where they were and who they were with and what they were doing. People who were more commonly home and alone, never leaving their house, reported that they were better at taking the bus, going to the bank, and work skills than
Mhm.
people with schizophrenia who are currently working full time. So
Mhm.
people were reporting that they were really good at doing things that they never did. So when
Mhm.
you talk about introspective accuracy, there's another layer in schizophrenia, which is are you reporting on an actual experience or not?
Right.
So, one of the things we see, and we think this is related to medication adherence as well,
Mhm.
is that people with schizophrenia will tell you they've been taking their medication when what they're actually saying is, I refilled my prescription.
Uh,
So I have my medication, right?
mhm.
That means I'm adherent.
It's a
We
loose
think,
association.
yeah, go ahead.
No, no. I was just.
And we think that this is the origin of people's reporting that they're doing things they can't possibly be doing. They're
Right.
convinced that they could do that stuff if
Mhm.
they had to or if the opportunity came up, but they're not doing it. So when
Mhm.
we ask them, how good are you? They're giving us a report on their self generated opinion of how
Mhm.
good they think they are at things, and not based on their evaluation of their success and failure externally originating of
Mhm.
what actually happens when they do something. So the idea is introspective accuracy is driven a lot by a bias toward not considering external information,
Mhm.
regardless of the reason that you don't have access to it, whether you don't do something or whether you don't pay attention. And
Mhm.
so you may not pay attention to feedback when you're doing a neuropsych test. You may not
Right.
leave your house. But the fact is, you form opinions on the basis of the information that you have, which is generated by you.
Right. So they're overly reliant on an internal narrative
Yeah.
that is unstable ultimately.
And in
Yeah.
fact, we just got funded by the National Institute of Mental Health
Mhm.
to develop an application, a digital app delivered on a smart device to get people to focus on the environment and the task at hand. One of the things that we saw in one of our studies was that people with schizophrenia, when we asked them to remember a word list and asked them then to tell us how many words they got right, it wasn't uncommon for them to say they got 14 words correct when only 6 words were presented to them. So
Interesting.
it suggests that there's an element of not focusing on the task
Yeah.
that leads you to not being able to sort of encode the
Hmm.
framework for remembering your performance and using that going forward.
And so they provide more intrusions as opposed to
Yeah.
the usual
The other
ones.
thing we saw was that there were intrusions.
Mhm.
Now, we compared people with bipolar disorder and people with schizophrenia. The people with bipolar disorder had just as many intrusions, but
Mhm.
if they were told that they were wrong, they actually gave responses at the end of the day that were linked into how often they were right and not how often they said they were right.
Right. I see. Okay. Now, we spent a fair amount of time talking about the deficits or the challenges. I'm wondering if there have been any paradoxical findings, ways in which individuals with schizophrenia may actually have shown improved performance.
Well, I think one of the things that we have seen is in this whole concept of hyper focusing. In the couple studies we just recently published, we found that people with schizophrenia were actually much better able to remember information they had generated themselves than healthy people were.
Hmm.
Now, we didn't want them necessarily to remember that, but there's got to be a way to build on that strength. So there is an unbiased ability to remember your judgments and decisions. So
Mm.
if this very intact, unbiased ability to remember what you thought was going on could be focused on what's actually going on and incorporating the feedback, that would be a real plus.
Right.
I think that we do see that some people with schizophrenia are able to tolerate adversity and hardship better than healthy people.
Hmm.
When we followed up people with schizophrenia during the COVID pandemic, we found that many people with schizophrenia were less upset about having to isolate and quarantine than healthy people were. They
Okay.
were actually feeling better that they were not being stigmatized for not having friends or social activities outside the house.
I see. Okay. That's really fascinating. I'd like us now to shift over to treatment. Um, Obviously, the best treatment usually tends to be both medication as well as psychotherapy and other factors. Could you give us, more specificity to that?
Well, clearly, one of the things that's been shown is if you have a combined intervention that promotes clinical stability, cognitive functioning, and skill acquisition at the same time, that
Mhm.
leads to the best outcome because people with schizophrenia are deficient in their skills
Mhm.
and they have cognitive challenges. But in a study that was done at UCLA, which was really fascinating, they showed that people in a randomized trial who were randomized to long acting injectable antipsychotics and cognitive training and psychosocial interventions had recovery rates that were like 5 times as high as people
Wow.
who missed out on any one of those interventions.
Mhm.
On the cognition side, computerized cognitive training works, but it has to be paired with skills training
Mhm.
because in Alzheimer's disease, for example, if you have a cognitive change, you have functional disability, you've forgotten how to do things that you could do before.
Mhm.
But if I gave someone with schizophrenia 10 IQ points and they'd never been on a job interview before, how would they know how to go about going on the job interview? So
Right.
skills travel separately from cognition.
Mhm.
Cognitive enhancement makes it easier to learn skills, but assuming that someone would just spontaneously go get a job because you gave them cognitive enhancement is sort of
Mhm.
like believing that they would spontaneously be able to play the piano or speak French.
Right.
Those are skills, you got to learn them.
Right. So, in a sense, it's pairing treatments for or interventions for cognition and executive functioning, specifically the part of translating those
And
cognitive
clinical
improvements.
stability, because
Right.
the clinical stability part seems to be a part of the equation that some of us used to argue in the past maybe wasn't as important. But the data from the study at UCLA suggests that we were wrong, and that clinical stability may very well be a prerequisite for progress in learning type interventions. Makes sense if
Mhm.
you're disorganized and psychotic, and you're distracted by other experiences, or you're focused on the inside, not the outside, it's very
Mhm.
difficult to learn.
Okay. When it comes to psychosocial interventions, I'm particularly thinking about psychotherapy. I believe the audience will likely be psychotherapists or people interested in it. What approach tends to be most effective?
Well, people have developed interventions that are uh, slightly differently delivered with the same general goal. One is what's called metacognitive training, or metacognitive therapy. Metacognitive therapy teaches people in person and with applications to evaluate their decision-making process, to evaluate the evidence they're using to come to conclusions,
Mhm.
which is very similar to the cognitive behavioral therapy that's been applied to target treatment refractory psychotic symptoms. The main focus of these interventions is on, first of all, getting people to do something.
Mhm.
Second of all, getting them to stop and think before they come to conclusions, and to consider the totality of the evidence, including their own opinion, but also feedback from others, before one makes a decision about doing something or engaging in some course of action.
Mhm. Now, are there differences in regards to efficacy when it comes to individuals who have higher IQ or a different background?
One of the things that's very clear is that there are two adverse impacts on these interventions, and that they're learning based interventions. So, people who have significant problems in episodic learning and memory have a hard time in learning based therapies. It's not
Right.
necessarily IQ as
Mhm.
much as the specific ability to learn new information. I think
Mhm.
that's highly important in that regard.
Mhm.
Further, you got to go slower because people have substantial processing speed challenges. A lot of them complain that the typical pace of classroom education is just too fast for them.
Okay. And how do psychodynamic or existential or other sort of types of therapeutic approaches fare when it comes to schizophrenia?
Well, most psychoanalysts say that they think that schizophrenia is not the prime target for psychoanalytic therapy.
Mhm.
And supportive type interventions. I mean, one of the things that has to happen is for people with schizophrenia to improve their functioning, they have to think differently and they have to do things differently. And if
Mhm.
all you're doing is supporting whatever the person is currently doing, well, they need to make some changes. I
Mhm.
think that a sort of structured learning based therapy that works with shared goals and identifying what people want to do. So, for example, my goal for this week is to have dinner at home twice this week and cook it myself. Those are
Mhm.
the kind of goals that are the things that these therapeutic interventions focus on, that
Mhm.
people tend to be able to meet. Whereas, a larger existential thing, I mean, obviously, people with schizophrenia are not experiencing psychotic symptoms 100% of the time. Most
Mhm.
estimates will place it somewhere between, 15 and 40%. But
Mhm.
if you're focusing on existential experiences and the experiences is psychotic in its origin, then it's not going to bring you closer to reality by focusing on that.
Right. So there's a very real practical element that needs to be incorporated, regardless of what approach that you're
Yep.
taking.
And it's been
Um,
shown that cognitive ability is a prerequisite for
mhm.
making therapeutic gains, and people need to keep that in mind and possibly consider concurrent uh, cognitive training, and also avoiding, drugs and other things that make your memory worse.
Right. So another line of intervention that's become quite popular is meditation. I'm wondering, are there adverse effects with meditation with individuals with schizophrenia, or has that shown to be
I
beneficial?
don't think there's enough evidence for me to give you a real opinion on that. I
Okay.
think that depending upon the goal and the ideation, I mean, one of the things that becomes challenging at times is that people's goals need some discussion and feedback. And meditation sort of is the opposite of being goal directed. You're trying to get things out of your mind, and
Mhm.
so I can't really offer a concrete opinion on that.
Okay. I'm just thinking about, the types of meditations that, like you said, focus on emptying your mind and perhaps focusing more on a non-judgmental view of what's happening around you, as
Yeah.
opposed to,
Well,
falling into your own internal narrative, like we
I think
just
that's a good idea, and relaxation never hurt anybody.
right. Okay. Are there promising novel interventions that you could speak about?
Well, there are a number of drugs that are in development that are not dopamine blockers for antipsychotics.
Mhm.
There's a drug that's being evaluated in 2 weeks that it seems to improve negative symptoms directly without interacting with dopamine. That could be a very big benefit. And
Mhm.
there are a lot of device based and training based interventions that are being examined.
Mhm.
Clearly, we land solidly on the side of computerized cognitive and skills training, but there are digital therapeutics targeting negative symptoms and stuff like that
Mhm.
as well.
Okay. So I know we're close to our time here, so I just have two more questions if that's okay with you. One is this is more broad based, and the question is, what has your study of schizophrenia taught you about the average individual without schizophrenia?
Well, I think one of the things that it's taught us is that the idea of misestimating your ability and having, both misestimating and having a response bias about your competence and your abilities is not uncommon. In fact, it's modal. And that I think that is the source of failure for a lot of people who don't have schizophrenia, is that they never stop and think about, what do I know? How good am I at this stuff? And should I be considering any alternatives? And we see that repeatedly in government and in corporate settings, where people just go walk down the same road over and over again. I
Mhm.
think another thing that we see that I've learned from this is the real importance of cognitive functioning in general and sustaining your cognitive functioning over the lifespan. We've
Mhm.
seen a number of really important studies delivering cognitive training to people who've been healthy over their whole life. And it shows that even though these people would not test as impaired, they get better at doing things that they have done for their whole life. So, for example, the active trial showed that computerized cognitive training made people in their 70s better drivers. And we could
Mhm.
use that in Florida. And so the idea is there are interventions that are rolled out within the SMI domain that could work in healthy people, and it's really a good idea for everyone to get some exercise and to do cognitively active tasks. And if
Mhm.
you're retired, there's things you can still do to keep yourself active that don't cost very much money, and you can buy them and deliver them to yourself.
Right. Quick side question. Is schizophrenia a progressive neurodegenerative disorder if it's not treated?
It's interesting because I think uh, when we look at pictures of people with schizophrenia from the early part of the 20th century, they look a lot more deteriorated than patients do now. We
Mhm.
also saw, uh, we started doing research many years ago, 1988, in a hospital in Long Island, where the average age of the patients was in their late 60s, but most of them had only had one psychiatric admission. These people have been in the hospital for 50 years at a time, and these
Right.
people were very deteriorated. So,
Mhm.
although people are afraid of antipsychotic medication, I think that no, lack of treatment with antipsychotics has evidence of being worse for you otherwise.
Mhm.
So the only thing that's worse than no treatment is starting and stopping your treatment.
I
If
see.
you are a person with schizophrenia and you are treated to clinical remission and you stop your medication and you relapse and you get retreated, you're going to lose 3% of your gray matter in
Mhm.
that one episode. Try
Wow.
that 20 times, that's a lot of gray matter. So there was no evidence of people with schizophrenia having no gray matter at the time they died before there were antipsychotics. But clearly, people were grossly deteriorated. So
Mhm.
I think what we're seeing is two things: that the more time you spend psychotic, the worse you do over the course of your lifespan.
Mhm.
And secondly, if you stop and start your medication, it's worse than never starting in the first place.
I see.
So, and the
That's
odds of actually stopping your meds and never having a relapse afterwards,
mhm.
it's about 2%.
Wow.
That's worse than the odds in Las Vegas. So most people should not bet that that's going to be their outcome. I mean,
Mhm.
obviously, everyone wants to try that for an experiment. It
Mhm.
should be a controlled experiment with someone who's watching you to
Mhm.
encourage you to go back on your medication if you become psychotic and all of a sudden, are not willing to listen to people. But
Mhm.
I think we have the degenerative part of it under control now, with the need for cooperation from our patients to take the medication.
Right. That's extremely important, I think, for those listening to think about. And with that being said, are there any last sort of words of wisdom that you might impart to somebody listening to this who's either struggling with schizophrenia or has a family member who struggles with this condition?
Well, it takes more than one drug to treat heart disease, right? High blood pressure, Lipitor, drugs targeting heart failure. It's going to take more than one intervention to make people with schizophrenia function better. And that it's going to include symptom control. It's going to include interventions focusing on skills acquisition and interventions focusing on cognitive training. And I think that that three-factor approach of skills and activity, cognition, and symptom management is the path forward. And the payers are going to have to realize that, and people are going to have to realize that just because you got someone not hearing voices anymore, if they were hearing voices and had no friends and no place to live, and they're not hearing voices anymore, they still don't have any friends or any place to live. So we need to focus on functioning and wide-ranging treatments.
Okay. And do you have links or resources that individuals who might be listening to this can go to that may be of assistance to them that I
Uh,
can maybe post at the bottom?
I can send you some stuff afterwards. I think that there are a number of highly informative websites, including
Mhm.
websites that come out from NAMI and
Mhm.
websites that come out from the Brain Behavior Research Foundation.
Well, thank you so much, Dr. Harvey, for all of the insight and knowledge that you've provided us today. It was a true pleasure talking to you.
All right. Well, nice to see you again, Aldrich. Okay.